Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
You bet. Thank you so much for having us. Yes, we are eager to share what we have learned since we started our Tacoma Max Clinic, and it has essentially been building the plane while it flies. And so we'll give you an overview of it, but we really keep learning. We've got so much to learn as we go. And so Kendria is all things programmatic for our entire HIV program, but then she also has helped keep this Max plane flying as well. So she and I are going to share the didactic today, so we'll kind of share some of the slides, but I look forward to sharing with you, and then we'll have some time at the end if you have some questions. So these are my disclosures. Kendria doesn't have any. And then I think because this is a presentation on low barrier, I think it's a great opportunity for us to emphasize that the data doesn't tell the whole story. And so this is a great chance for us to kind of highlight what we get to see down in Tacoma. So the objectives today, we're going to provide an overview of our low barrier structure in Tacoma. How are patients eligible? How do they get referred to us? We'll give a little oversight as well on the walk-in model and then how we incentivize care and what has worked for our location. We want to show what the staffing and roles look like because it is very heavy on staff, and I think that's an important consideration just from a cost standpoint of can you model something like this after what we've been doing. We'll walk through some project management tools. So what has helped us stay organized when we have 3 different agencies trying to do the work together. And then we've got some data and some clinical outcomes that we'll share both from the Max side and then a bit of a comparison to our Ryan White program in patients. And then we'll end on some lessons that we've learned with time. So really it actually started out of the HPSG, the HIV Planning and Steering Group that the DOH brought together. And I'll just speak from my perspective. It felt like a lot of the conversation continued to be around King County. And so the Pierce County folks were like, don't forget us. We've got need. Our outcomes aren't as good. And so out of that and out of some of that passion by 3 of these agencies, we were able to get funding through the Department of Health to launch the Max Clinic. So the 3 agencies are my own agency, Community Healthcare, the Pierce County AIDS Foundation. So they are a case management agency in town like Lifelong, if you're more familiar with Lifelong, very similar case management based agency. And then our local health department called the TPCHD. When we sat down with DOH hadn't done this before from kind of a triple agency perspective, and then clearly we hadn't done that. We'd worked side by side in a lot of projects, but not kind of on a mutual project. So when we were funded, the funding was separate. So the DOH funded CHC, contracted with us, separate from PCAF, separate from TPCHD, yet the mission was for the 3 of us to work together. And then really the purpose of it is looking at our system and looking at the patients that were being missed by a traditional, you have to have an appointment, 8 to 5, banking on transportation, and really that their needs were being met outside of their medical care, that we were missing a lot of patients. So it really was created to try to address these complex medical and social needs while also taking care of their HIV. It is housed within CHC, so employees from different agencies are working together to take care of patients who come to our clinic to have these services. The clinic where it is housed also has a lab, is on a bunch of bus lines. Trying to describe what else is there. We have a behavioral health program. We have an urgent care in the building, a pharmacy, and a lab. So we tried to have it in a place where there was access to a lot of services, yet we are kind of the house of the program. Did you have anything else to add on that one, Kendria?
So my name is Kendria Dixon, and I am the HIV program manager here at Community Healthcare. And I'll talk a little bit more about our approach in involving the fieldwork, case management, peer navigation, and our comprehensive medical services. The overall aim, as Shauna mentioned, of the Max Clinic is to really create relationships and build trust and to strategize with patients on how to achieve viral suppression and or other positive health outcomes in that non-traditional clinic setting. So to date, the Max Clinic has about 44 active patients enrolled, and we've been successful at engaging more than 300 people into care through this non-traditional low barrier approach to HIV care and treatment. And as Shauna mentioned, the Max Clinic is modeled after the high resource academic institution, but we want to talk to you all a little bit today about how it's also proven to be successful in a community health clinic setting with local agency support. I'm going to talk a little bit as Shauna advances the slide, the eligibility criteria and referral process. To qualify for our Max Clinic, patients must meet one or more of the following criteria, and Shauna will get that on the screen shortly. And so we really look at folks who are not well engaged in HIV care for a year or more and have a detectable viral load or a missing viral load. And so that's looking at our patients that are facing significant barriers to care that require more of an intense case management and or peer navigation approach. And so that might include things like chronic homelessness, untreated mental health conditions, substance use disorder, or any other significant barriers or lack of social support. And so if a patient meets those criteria, they can be referred to our Max Clinic. And all of the referrals are reviewed by a team with the final approval being by the clinician. And so we use a standard referral form, and it includes referral information like contact information, the name and agency that's referring the patient to the Max Clinic. As we mentioned, we do get referrals from our other clinic partners. And that also referral form also includes medical information, last viral load, last CD4, last medical visit, last provider. And then we also ask on that referral form for case management information. So that's things like insurance status and any other known patient needs. For example, if the patient is in a current crisis, we'd like to know that information ahead of time as well. And so in some instances, our patients are referred to the Max Clinic. They may be hard to reach. And so in that case, we utilize our local public health agency, and they will deploy their disease investigated specialists to attempt to locate the patient. And this is super important as the DIS worker from our local public health agency typically has more access to records and health data and can use those non-conventional methods to investigate the whereabouts of the patient. So that looks like doing field visits. I would say most of our referrals are patients that have had previous engagements with the clinical or case management teams. And again, the teams really utilize working together to enroll them into the Max Clinic and to keep them engaged in care. So the next slide is talking a little bit about walk-in services. So once the patient is located and they're ready to engage in care, the patient signs a multi-agency ROI and a contract outlining the Max Clinic services and the commitment to participate. And so patients are able to walk in Monday through Friday from 8 a.m. to 5 p.m. and they're assessed by both the clinical practitioners and our clinical side as well as the support service teams. And so just on the slide, we can see here the ways that we do that assessments, both on the clinical side and then the support services side. To talk a little bit more about the clinical aspects, community healthcare has been providing HIV primary care since 1991. And in 2014, we received HRSA HIV and AIDS Bureau funding to support the delivery of essential medical care and support services to people living with HIV. And so over the last 10 years, our program has expanded, our general HIV program has expanded to servicing nearly 750 patients. And so that program is the second largest HIV practice in Washington state. And so within our larger HIV program, the Max Clinic has the capacity to care for up to 50 patients. And those particular services, again, are geared towards patients with complex medical or social needs and that are not well engaged in care in its traditional setting. So to talk a little bit more about the HIV funding for the Max Clinic, it's funded by Ryan White Part B services, which provides grants to states and territories and funds core medical support services. So we are subcontracted under the Washington State Department of Health, and we are funded particularly for outpatient and ambulatory health services. So that's the clinical and programmatic supplies, clinical supplies and things like that. We're also funded for medical transportation. So we use Uber Health for that. We're funded for essential needs items and funded for emergency financial assistance. So that's us providing motel vouchers and things like that. And some of our partners are funded in similar ways. So to prevent duplication of services, we really rely on that clinical assessment and the medical need as documented by the provider in order to activate those services within our Max Clinic. Okay, so this is a little bit about our structure on the support services side. So our case manager and peer navigator are provided by PCAF, that's the Pierce County AIDS Foundation. They're the local ASO. And those services include assessments of clients' social needs. And they really develop a comprehensive individualized care plan looking at the social needs of those patients and really support linking the patient to federal and state assistance programs and any client-specific advocacy. So we are still working on a staffing structure that meets the needs of patients and honors the unique contribution of each partner agency, but we're really finding that this method of working all together in a multi-agency partnership has been extremely successful in looking at patient outcomes. So I'll talk a little bit more about the incentives. So the incentives are provided when patients meet specific health outcomes. And so one of those could be, for example, having an undetectable viral load, or patients that may have other health outcomes that are assessed by the provider that we've also provide incentives for. We also have programming for non-incentive vouchers. And so that's when there's a documented social need according to that ISP that the case management part of the organization has provided. So we provide things like medical transportation, in-clinic snacks, and the frequency of the vouchers distribution was established in the beginning from our organization, depending on our funding, and it has since been reviewed and updated as we have seen needs have changed over the course of the last couple of years with things like COVID and other national crises happening in our world. So we've also have a space to that those vouchers distributions and the frequency can be reviewed as needs change. The other thing about the vouchers is that they are tracked and monitored by the programmatic staff. And so that's kind of my arm. And we do this to ensure equity and appropriate use of the funds and also to limit duplication of services with our multi-agency partnership. And we do make exceptions of voucher frequency, as I alluded to before, on a case-by-case basis. So if a patient comes in and the assessment from the provider is that they need some services, we definitely take that on as a case-by-case basis and can adjust that voucher frequency as needed. Okay, so talking a little bit more about the staffing and the roles. At community healthcare, you can see on one side, that's the CHC clinical side. We offer in the Max Clinic, the clinical team and also the programmatic team. So the clinical team is led by Shauna and is responsible for the clinical assessment, triage, prescribing medications, and overall patient oversight. And then the programmatic team, which includes myself, is a team that looks more so at grant compliance, distribution of incentives, tracking of budget and services, and any other administrative oversight. We also, I think, as a new program, we've been looking at how does the programmatic team also do some outreach in conjunction with our clinical team. So more to come on those kind of innovations we've learned over the years. So staffing roles at our partner agency, that's PCAF and TPCHD, who are also both Ryan White Part B funded. And as Shauna mentioned in the beginning, we are all funded separately within the Department of Health. So we have put the FTEs here as an overall estimate. We don't know exactly the specifics of the FTE breakdown or funding allocations. And so we have provided the estimates here. And I think that was one of the lessons learned, as Shauna will talk about in a few minutes, is what that looks like for multi-agency partnerships. And we had suggested that having an overall scope of work with some of these things outlined in the beginning would have been beneficial to our partnership in the beginning. Okay, so looking a little bit more broadly at the staffing model comparison. So our general HIV program, as I mentioned, we have around 750 patients, and it is staffed with the following FTEs. And then the Max Clinic staffing model was established for no more than 50 patients. And so just a caveat here, like other organizations, the pandemic really altered the way we delivered care. And so as a clinic providing essential medical care, community healthcare did not close their doors during the pandemic. And so our task at that time was really to work with our partners that might have had different agency expectations. And we really worked well to navigate what remote work looked like or what limited staff capacity looks like. So that, again, would be one of our recommendations. And Shauna will speak to that a little bit more about having those conversations early on so expectations are managed in the beginning. So I would say we're still working on staffing structure and making sure the organizations have what we need in terms of helping patients and really honoring the unique contributions of each partner agency. So we worked together, and this is more of my wheelhouse, is the project management tool. So we worked quite diligently when I came on to CHC about 4 years ago to really create a blueprint for the Max Clinic, again, as it was modeled after an academic setting that may have had more established partnerships and systems in place to really facilitate the collaboration. So we are attempting to replicate that at a local level. And there were a bit of coordination pieces that were needed to integrate the activities across the agencies. And so I'll share with you all a little bit more about some of those and how we've been able to kind of get everyone on the same page working towards that same goal. This is an image of the roles and responsibilities document and also some of the policies and procedures and flowcharts that we've established in our Max Clinic. And so the roles and responsibilities document was derived out of a need to establish service provisions and contributions for each of the agencies. And so CHC and the Tacoma Pierce County Health Department operate under a medical model, and that follows really a structure in decision making and is governed by policies and procedures, and often has the medical provider at the center of that. And so we recognize that model is a bit different from our PCAF partners, which are that ASO, and they operate under a social work model that values client choice and decision making in that is flexible. So the roles and responsibilities document was a formal way of defining which roles each agency is taking on and really their book of business, and which agencies would be responsible for managing the expectations of the project. So creating the document together really encouraged cross-agency communication and fostered more of a collaboration effort. And so each agency really spent some time outlining those roles and responsibilities. And we felt that was really successful in moving our partnership forward. And so similarly, each agency has a separate set of policies and procedures. And so CHC opted to use this visual flowchart to ensure that CHC's process is detailed and that staff that are coming in our space and at the other organizations also are aware of what we are doing as a Max Clinic on the CHC clinical side. So we also have a lot of meetings and conversations, as you all can imagine, in managing this partnership. So we really found that creating a meeting template and utilizing some more of our forms helped communicate across the agency. So we found that scheduled and frequent communication was essential for our thriving partnership. And so we created a standing meeting schedule, and we have 4 meetings that are occurring regularly with all of the partner agencies. So one of those meetings is a leadership meeting. And so that happens one time a month. And that's a larger agency discussion on ways to continue to look strategically at our partnership and really have the input of the key leaders that are in our partnership. And then we also have operational meetings, and that also happens one time per month. And that includes all staff. And in those meetings, we address programmatic concerns, questions that come up, more so about the overall operations of our multi-agency partnership. And then we have monthly clinical meetings. And again, that happens one time per month. And those are quick reviews of the entire patient list. Those are looking at our referrals, our graduations, what patients may be experiencing more barriers, and how will we help them in a clinical aspect. So those monthly clinical meetings are ran by our providers, and they really do that quick review of the entire patient list. And then our last meeting is weekly huddles, and that happens once per week. And that's a breakdown of the priorities that were established in that monthly clinical meeting. We decided that it worked well if we break down those priorities in more of tangible weekly assignments. So each agency has assignments, and the progress is reported and tracked on that weekly meeting template that you see, and we call that our weekly assignment tracking tool. And so we found that that was really successful in our partnership in making sure that each agency is communicating their priorities for the week. And then the other form that you see there, really our forms serve 2 purposes, and most of it is for grant compliance and adherence to the requirements. And so to clearly document our clinical need for incentives, we have created the forms that have questions to prompt our clinical staff to evaluate the medical linkage to the incentives. And so we have our staff to complete these forms, not just for the transportation one is the example, but we have forms for all of the incentives that I mentioned before, again, to be in grant compliance and adhere to the requirements of the Ryan White program.
Awesome. Thanks, Kendria. So we wanted her to kind of give programmatic side that there really is a lot of structure that is needed to coordinate staff from 3 agencies. But also we have patients that really need a lot of support. And so that structure kind of lays out who's doing what so that patients don't get missed or their needs don't get overlooked. So I wanted to just give a little bit of information about our patients. The numbers are in flux all the time. I think right now we actually have 47 patients, but when I took the data, we had 44. So this isn't perfectly accurate, but I'll give you a little overview. So the majority of our patients are cis men. We have actually 34% are Black individuals, with 59% being non-Hispanic white. So that's really the primary population that we're serving. And that's really representative of what we see in Pierce County. And then our age breakdown, I was interested to see this. I don't think about my patients' ages as I see them, but as I pulled this out, I was surprised to see how many of them are genuinely over 49. And that's what the national statistics are looking like too. So this is a look at some of the data outside of demographics. So the way I pictured it is, what did they look like when they enrolled in MAX? And then what have we seen most recently? So of course that timeline's different for each patient, but this way you can see, have we made any progress in some of these outcomes? So on the left, if we're looking at these individuals, what I'm trying to lay out is that 35 of the 44 had a viral load that was detectable. 9 of them had an undetectable viral load, and so that percentage was about 20%. I'll keep going down and then we'll move to the right. Their CD4 at baseline, you can see, is listed there. It's a pretty even split 3 ways, of about a third of them being under 200, about a third of them being between 200 and 500. and then about a third being more than 500. So again, this is kind of on intake into the Max Clinic. And then if you look on the right, this is what did we see with the most recent lab values. So the percent of patients that are undetectable is significantly better, 54%. Of course, we'd love for it to be better, but when we look at patients who are houseless, substance using, some kind of mental health diagnosis, and otherwise weren't engaging in care, this feels like a really great improvement and a good outcome for our patients enrolled in Max. And then their CD4 counts are listed again, most recent. So a smaller number of patients with a CD4 less than 200, about a third at that 2 to 500, and 43% at more than 500. So some other characteristics, and I call these out because they really are a larger percent in our Max population compared to our Ryan White patients. I tried to break out the substance use and also talk about, well, if they are substance using, are they receiving any help with that? So we had 27 out of the 44 patients, or 61%, who are actively using some kind of substance. And I broke it out here with opiates who are getting opiate replacement. That's the first bullet. Opiate use without replacement, 15% there. And then other substances, we have quite a bit of alcohol and methamphetamine use. And so that's listed in that third bullet. Part of our clinical team is a behavioral health team, which includes a psych nurse practitioner and a behavioral health consultant. So though 77% of our Max patients have some kind of mental health diagnosis, 68% of them are engaged in our behavioral health program and receiving medications for that. So that also seems like quite a worthwhile intervention that is offered to them through the Max. And then at the time, 32% had unstable housing. That really fluctuates. Sometimes it's more than 50%. Sometimes it's low like this. So that's also something that's not consistent for our patients at any given time period. And then this slide, instead of only looking at our Max clients, is a comparison between our Ryan White versus our Max. So our Ryan White patients would be in the orange and the Max patients are in the blue. So on the left, that graph is looking at viral load suppression over time, and the time period is just a 6-month period. So what was their viral load suppression at enrollment is your first time point at 3 months, and then at 6 months. So there is a difference between Ryan White and Max, but a significant improvement for both over time by enrolling and participating in medical care at CHC and in the Max program. And then on the right, I tried to model the care continuum, again, comparing Ryan White in orange and Max in blue. We do a rapid start in our Max, and so that's part of why that second bar graph is so high, is because really if they come in off meds, there's not a lot of good reasons we don't start them on meds right away. So that's great on both ends. And then remaining on ART, the way we define that is at the 6-month mark, were they still on medication? That was kind of our definition there. Still really good in both arms. And then the last is sustained suppression, and I define that at the bottom of the slide. That's where they had at least 2 values that were less than 200 copies within that 6-month time frame. So again, really good on both sides, difference between the two, but I think a great win for our population that faces so many barriers and otherwise hadn't even walked into the clinic prior to this. The other thing we're doing is a qualitative study where we're looking at patient-reported outcomes, and Dr. Andrasik actually helped us on this, and she developed the survey questions and the interview questions. We're just about to wrap it up. I think we did our last interview last week, so now we're just pulling the data together. But essentially what we wanted to do was see what was the patient experience with the healthcare system, and then what was helpful both on the Ryan White side and on the Max side. I loved one of the answers on the Max side was that they identified themselves as the biggest barrier. I felt like that was really good insight that they were able to then share back with us, that we can partner with them and build kind of a plan that they're a part of and maybe help themselves make themselves less of a barrier moving forward. So it's been kind of interesting to see how people engaged in this and what their answers were to the barriers. In particular, I think we look at we were coming into Max thinking there were all these barriers that the patient themselves had, but we have learned quite a bit about the barriers that the healthcare system puts up, and how can we help reduce those barriers to help them be successful with their health goals. So Kendria alluded to this, and we've had a lot of time to think about this because it actually, I don't think I shared this. We started in 2019, then we endured the pandemic and kept on going. And now we're in a restructuring phase of like what's worked, what hasn't worked. Had we known what we know now, what would we have done differently? And I think one of the biggest things is making sure the mission and the vision is co-created at the time of inception, because I think then you can always go back to that, and that drives the work you're doing even when things are challenging. And that also helps you set those very clear expectations of each agency. Each agency has funding priorities, models of care, and we had to learn that. We did not know that the different models of care would really need to be worked through so that we could be productive together. So I think just understanding what are the funding priorities, what are the goals of each agency would really help. We are funded separately, and that is one thing we would do differently, is we would get one funding. We would like to be funded as one with subcontractors, because I think that really sets better accountability for the work each agency is doing. So that's just me dreaming. That's not the way it is now. But had we done it over, I think I would have requested that it be one main contract. Talked a bit about the multidisciplinary, just a place for people to come together and feel valued. And yet, how are we going to take these different approaches and make them efficient and workable with each patient? And then partner management, how do we keep our staff and our providers knowledgeable, educated, supported, because this is a hard population and it can make people very tired. And so we are always looking at different trainings, DEI trainings, professional boundary setting, trauma-informed care, secondary trauma. We have a lot of secondary trauma as we walk with our patients, and how do we keep our staff engaged and feel like they're supported. So that would be the list of our lessons. I think I'll pause here and let Echo guide me from here.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button, and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.